Good afternoon or good evening, ladies and gentlemen. I would like to welcome you to this very interesting evening symposium, which is called The Next Step in Disease Management from Interventional Pulmonology Perspective, focusing both on lung emphysema as well as nodules. Could I ask the technical support to shut down the music, please? Otherwise, I'm tempted to dance, and you don't want that to happen. We have the opportunity to discuss with a group of experts some very important topics. A symposium that is supported by Bronchos and Uptake Medical, basically looking into two specific fields. And I think from the clinical perspective, you all know that emphysema is a big clinical field. There is a huge number of COPD emphysema patients that are looking into treatment options. I personally see that happening on a day-to-day basis, that patients with advanced disease are approaching myself and other colleagues looking for technologies to help them in their everyday life. And actually all the clinical trials and efforts in the IP field over the last couple of years have contributed to the fact that there is more information out there. So patients put some search items into Google when they have relatives or are affected themselves, whether there is additional COPD treatment. And once they do that, they get a lot of mixed information, and then they come to us physicians asking whether this or the other technology is an option for them. So I think it is becoming increasingly more important to be familiar with the appropriate patient selection, which is going to be a big part of what we're going to discuss today, as well as about the technologies in general that are out there. And that's the emphysema COPD part. And when we talk about sort of a similar smoking-related disease, we are very quickly entering the field of lung cancer or lung nodules, particularly given the multiple clinical trials in the field of lung cancer screening. And as you know, even if there is no systematic lung cancer screening in some of the countries available for reimbursement issues, we still face an increasing number of CT scans. The threshold for performing CT scans in clinical routine is much lower, obviously, today because of the wide availability and because of the lower radiation exposure with the novel devices and novel CT scanners, that the threshold is lower, therefore more CTs are available, therefore we get to see more. And the more we get to see, the more we have to have an appropriate idea of how to approach various incidental findings in a high-risk population, and we'll also talk about the way to diagnose and potentially treat these lesions in the lung if we have confirmation of malignancy. But I will personally start with the field of emphysema, and I would like to give you a high-level overview about the road over the last 10 years, if you want, and where we were coming from and where we're heading when it comes to emphysema treatment using bronchoscopic thermal vapor ablation. And this is a very basic slide here demonstrating to those of you who may not be so familiar with the history and the path of the last 15 years that this technology that we're discussing today is already available, or the concept of the technology is already available for many, many years. You see that Uptake Medical was founded in 2005, and there have been some preclinical studies. And there have been a number of clinical studies starting in 2008. And with this history, moving from very early feasibility towards early clinical trials, I think the experience, both from a clinical perspective but also from a scientific perspective, has been very helpful to identify the group of patients that may benefit from BTVA treatment. But again, coming back, it was sort of a long way, if you want, using multiple approaches, dose finding studies, looking into different outcomes, usually starting with safety outcomes before we moved into the field of randomized controlled studies. And it was certainly the Vapor trial, which was published in the ERS some years ago, that has demonstrated that if we treat patients with upper-lobe predominant emphysema with vapor on a Lobar basis, that there is efficacy that is relevant in terms of lung volume reduction, but it was also clear that the efficacy may not be balanced appropriately by the safety using a Lobar approach. And this is a publication from a post-hoc analysis of that Valipour study, showing that once you have treated more than 1,700 mils during a single session, that the risk of adverse events identified here by yellow or red bars is just increasing dramatically. And this threshold was used and provided the justification to use a slightly different approach of a Lobar treatment, moving into segmental treatment for selection of most disease areas of the lung. And you can see here, the idea really is to use a very sophisticated CT analysis to stratify individual segments that may be more affected by emphysema than others. So like here in the right upper lobe, RB3 seems to have little or no emphysema, and RB2, for instance, may have much more substantial emphysema. And if there's sufficient heterogeneity both to the contralateral, to the ipsilateral lower lobe as well as to the adjacent segments, then these patients may be eligible for segmental treatment. And this approach was used in a subsequent randomized controlled study that has been published in the meanwhile, both 6 and 12 months results. It was a multi-center study, small sample if you want, but very well conducted, looking into primary endpoints of FEV1 as well as SGRQ. Using the typical in- and exclusion criteria, I probably don't have time to go through all of these, but I guess everyone in the room is familiar that we're talking about a specific phenotype of patients with upper lobe predominant emphysema. They have severe hyperinflation. They have to have some level of preserved exercise capacity, and we're trying to avoid patients that may be affected by severe pulmonary hypertension, severe hypercapnia, or other causes that may contribute to dyspnea, such as heart failure. And the exclusion criteria basically are to ensure that patients are more or less stable enough to undergo these procedures. Particularly when it comes to frequent exacerbators, these patients have not been included in any of the ongoing LVR or past LVR studies. That said, I would like to make a short comment regarding exacerbation in general. I think in the clinical environment, we have to have a very clear understanding whether these are true exacerbations defined by inflammation and infection, or whether these are symptom-driven medical attention-seeking patients, if you want, where the indication for exacerbation treatment, which defines an exacerbation, is actually dyspnea due to hyperinflation and not an exacerbation due to an infection. So that said, I'll skip that and go to the demographics of that study just as a sort of short summary. You see here patients had on average an RV of 230, indicating that there was severe hyperinflation. They had an FEV1 of 33%, and they had, which I think is important to remember, majority of these patients, but not all of them, were CV positive. That means this is a patient group predominantly selected on the basis that valves are not a treatment option, but still around 20 to 25% of patients, even if they're CV negative in this particular study, have been included. What is very reassuring in my clinical experience, having treated now more than, I think, 40 or 50 patients with BTVA over the last couple of years, is that the procedure time is really short. We do that with conscious sedation or with short anesthesia. It usually takes somewhere between 8 to 12 minutes if you treat a patient. And the patients wake up. The short procedure time also ensures and contributes to the safety. This is the data that has been published. 6 months results have been published by Felix, and the 12 months results by Pallav Shah. And you see here a consistent improvement in comparison to the control group in this study. Need to remember, this is not a sham control study, so therefore the subjective improvements in SGRQ may need to be corrected for the intervention effect, but certainly the lung function improvements speak for itself. The magnitude of response you may see here may not be to that extent that you may see with valve treatment in the Liberate trial, for instance. Jerry Kreiner is here. But what is certainly reassuring is particularly the safety data. compared to, for instance, pneumothorax rates, which are much higher when it comes to valve treatment. And this was also the rationale to conduct a prospective registry where we could also within a real-world environment collect data to see whether the safety data that was more or less reassuring during the randomized controlled trial can be replicated in a real-life environment. And the data I'm presenting to you right now basically stems from this prospective registry. The primary objective of this registry is to describe the long-term impact of the intravapor treatment on patient quality of life. So if you want, the primary endpoint would be the SGRQ at 24 months. Given that the registry just started about 1.5 years ago, we don't have any data in terms of the primary endpoint, but I will show you some interim analysis if you want, and also looking into safety as well as some secondaries. Again, the main data I'm going to present to you today will look into some of the safety data that are also part of an oral presentation on Wednesday morning. So patients who underwent the procedure may have been treated unilaterally or sequentially and bilaterally, and the follow-up time was per hospital protocols. Some institutions may do very close follow-ups with like after 1 week, a month, 3 months, and 6 months. Some may expand these intervals depending on availability, the distance to travel for some patients. But what has been requested is to complete a questionnaire about symptoms. What is included is a simple exercise test, such as the 6-minute walk test, as well as spirometric data. Multiple sites have contributed to this registry, and I'm thankful for that, and I guess the company is thankful too. And you see, as of, I think, 2 or 3 days ago, close to 100 patients underwent their first treatment. Only few patients so far underwent the second treatment. So since this activity has been increasing over the last 6 months, there is ongoing data collection, and the data replicates very similarly what you've seen before in the randomized controlled trial. And that means that in the real-life environment, the patient selection seems to be very similar, which is very reassuring because usually, you know, once something is available commercially, physicians may tend to expand that pool of patients, and that may still happen, but the average FEV1 is around 31%. RV is maybe a bit higher on average compared to what we saw in the step-up study, but again, the SGRQ with close to 60 points indicating a patient population that is highly symptomatic. Average age indicating and reflecting a typical COPD patient population. So these are so far, again, based on small numbers. The 6 months follow-up is based on 44 patients so far. Some of these patients only had unilateral treatment. Please keep this in mind when critically evaluating these numbers. And you see that in terms of percent predicted numbers and in terms of improvements in milliliters of FEV1, there is rather a modest improvement. However, again, this is a potentially unilateral treatment with regards to this data, but treating with vapor has the potential to treat repetitively, subsequently, and to ensure that the patient has the opportunity to come back. I personally have few patients where I, for various reasons, thinking that I'm starting with one side to see how the patient does, I may not necessarily treat within the first 2 or 3 months after the first procedure and may get the patient back in again after a couple of months. And some other patients who are highly symptomatic and highly hyperinflated, I personally rather try to treat sequentially within 3 months of the first procedure. The SGRQ improvements appear to show somehow same benefits or similar benefits to what we saw with the 6 months data in the step-up trial, so that seems to be more or less pretty consistent. And I think what's important is the reassurance that in terms of the adverse event rates, we do still obviously see a more or less large proportion of adverse events, but not all of them are serious to the extent that they are related to respiratory causes. The number of related to procedure SAEs, so SAEs that have a connection to the procedure itself, have been labeled with 22% up to date. Given that these are patients with high risk for any procedure, we are more or less within the same frame and range of complication rates we see with all the other technologies, being it coils, being it valve treatment. The actual typical adverse events you see is pneumonia or pneumonitis. You don't have to forget what we're doing is thermal injury causing pneumonitis. Whether you call it an adverse event or whether you call it a desired side effect is, I think, a matter of discussion definition. Certainly, as physicians and as clinicians, we are tempted to treat those events because the patient may feel symptomatic, may have fever, may have dyspnea, so these patients get treatment for their pneumonia. COPD exacerbation numbers are lower to what we have seen in the randomized controlled trial, but certainly one of the reasons is that during a registry, data collection is never so good than during an RCT, so whatever I'm going to show you always has this limitation in mind. And this is, I think, a nice way to present the data, to show you what adverse events looked like in the step-up study and put this next to next in terms of the registry data that I've shown to you right now. And you see on average the numbers seem to be much smaller in the registry. Again, keeping in mind that two things may contribute to that. First and foremost is that during registries, data reporting AEs may be much more liberal. And on the other hand, this is based on many patients who underwent unilateral treatment. If you treat more aggressively, you may see more side effects on average. There has been 3 patient deaths with an overall mortality of 3%. And I think this is certainly something that when it comes to establishing such an treatment in your environment, if it's in your environment, you have to have the right tools and right patient selection and right environment to know how to take care of the post-interventional follow-up period, to be aware of things such as anticoagulation therapy, to make sure that the patients are getting in contact with you or with seeking medical assistance once they have hemoptysis or fever. So these are things to keep in mind. So to summarize, I've tried to give you again a very high-level overview of the path, where we were coming from, how long the technology is available on the market, and what's now happening in a real-life clinical environment. Certainly, I think all of us who are involved in this field agree that what we do need, basically, and what's hopefully will happen, is a randomized controlled study looking into both upper and lower lobe predominant emphysema to treat segments that are diseased and to see whether the data we have been able to obtain during the step-up study are duplicated also if you treat in a whole lung fashion. And this requires a formal prospective randomized control study. Thank you. So given that we have few minutes time, no, actually we don't have much time. We still have time actually, yes. 3 minutes left. Are there any questions before we move to the next talk?
Great presentation. A couple of quick questions. One is, have you had the opportunity to allow patients home immediately after the treatment rather than keep them in hospital overnight? Did you have to admit everybody after the procedure?
So I think that, again, depends on the hospital protocols. In our hospital, yes, I keep them even for 48 days. I know that in other institutions or other countries, it's been seen as an outpatient procedure completely. I'm living in a country where I have the liberty and the luxury, if you want, doing that. I know that depending on resources, this may not be possible in every other institution. So personally, I would say yes. For valve treatment, you know, the average recommendation is at least 3 to 5 days. Here, for my colleagues, I've instructed them to keep the patient for 1 or 2 days at least.
The reason I ask is in the UK, we don't have the luxury. The limiting factor often for emphysema therapy is beds.
Yeah.
So the 3 procedures that I've done twice, I've sent the patient home the same within 3 hours of the procedure.
And I think, and I'm sorry to interrupt, I think that's actually okay, because usually if you're running into troubles, they will occur later anyway. So I think troubles in terms of all of these troubles can be managed. So the patients receive steroids to go home with anyway. And I think what can be done if you don't have the resources in hospital, just keep a close outpatient contact with them, getting them back in after 3 days and maybe 7 days again. And I think that's the important part here. If you don't want to admit them, make sure you're getting to see them in order not to lose control over the scenario.
And do you get an idea that those who get pneumonitis respond better, like the pneumothorax people?
Absolutely. Yeah, I mean, that is my observation. I don't know whether anyone else would disagree with that, but certainly. And I think one notion of caution, if you want, not necessarily caution, is that what personally I don't know, and I don't know who knows, and I'm happy to have input from anyone else who's sitting here, is the somehow heterogeneous response to vapor. So and I think many other physicians experience the same thing, and I've just had a discussion with Kite about that. I don't know whether he's here or not. That he's there. Sometimes you treat a patient on the one side and nothing happens. And the good thing is if nothing happens, there is also no adverse events. So I think nothing happens also means the patient is fine going back home. It doesn't have any side effects. And then you treat the other side 2 months later, and there is a severe pneumonitis with hemoptysis and pneumonia. And I just had a recent case, and it just resulted into a longer hospital care. And the patient went back home, and he came back again after 1 week for another COPD exacerbation. We treated that. And all of that sounds very terrifying. But on the other hand, if you deal with that in a controlled environment, and then we sent back the patient home again, and he came back for his first PFT after 3 months, and after 6 months, and after 1 year so far. His RV reduction was 1.5 liters, 1,500 milliliters. He has a new life. This patient improved his FEV1 from 24% up to a total of 37%. And the first 2 months was tough, but then he responded amazingly. Yeah, you can't within a registry. The only thing that would be helpful is the timely association. So most likely any exacerbation that occurs within the first 30 days after the procedure most likely somehow related to the procedure. But of course, if you don't have a control group, you don't. So there's no honest, proper association whether this is related to the procedure. There may be one final note there, because I think we have to move on then, is that usually these patients are not frequent exacerbators. So once they have 1 or 2 exacerbations over the first 6 months after the procedure, since they haven't had any exacerbations before, you may consider that being potentially procedure related. But again, if you know what to do and you take care of these patients and keep them in sort of within your environment or close contact, or even if they're not within your region, then give them appropriate care how to deal with complications if a GP or a pulmonary chest physician has to take care of these patients. Okay, I think for time reasons, unfortunately, we have to move on, but I'm happy to take any questions afterwards. I would like to kindly ask Tina Contogiani, who's working in Heidelberg, to talk about the next step study. I've already highlighted a little bit of that, the opportunity not only to treat upper lobe heterogeneous emphysema, but also potentially homogeneous emphysema with some intralobar heterogeneity.